I am Dr. Anil Parekh, President, Medical Affairs and Clinical Research, IPCA. It's my great pleasure and privilege to welcome you all to this evening CME of Towards Greater Clarity on Issues Related to Hypertension. And this evening CME is carried out under the auspices of World Hypertension League, and it is during this month of World Hypertension Month. And it's our privilege to welcome all the faculty, both international and national faculty. And the faculty includes actually virtually authorities on hypertension and world's who is who on hypertension. So it's going to be an academic feast for us, and it has been always been an endeavor of IPCA to involve both national and international faculties on doing this CMEs, which we first started in 2011 when we introduced chlorthalidone, reintroduced rather chlorthalidone in the Indian hypertension market with a new dose of 6.25 and 12.5 milligram. And yeah, we are having academic and educational collaboration with our World Hypertension League, European Society of Hypertension, Indian Society of Hypertension, Singapore Cardiac Society. We conducted program earlier, British Ireland Hypertension Society, and to moderate on this evening CME, we have our own Professor Venkat S. Ram, and we are really fortunate to receive his guidance over the years on hypertension. And everybody in India knows Dr. Venkat Ram because of lifetime devoted to hypertension, both research, practice, and academics. Currently, he is Director, Academic and Scientific Affairs, Indian Society of Hypertension, Professor of Clinical Medicine, University of Texas, Southwestern Medical Center, Director, Texas Blood Pressure Institute, Dallas, and Dean Maguire University, Sydney, Australia, Indian campus, and founder member of ASH, American Society of Hypertension, and served as Chairman, Board of Governors of ASH, and rated as one of the topmost hypertension expert in the world, who is who on hypertension and issues related to hypertension, author of more than 410 publications and various books and chapters, and recipient of the Lifetime Achievement Award, Moser Award from American Society of Hypertension, received Padma Shri from the Government of India, and Health Minister, former Health Minister Harshvardhan, calling him icon of the on hypertension. So I welcome Professor Ram on this, and then I'll introduce the other international faculties which are there, and we have Dr. Gian Franco Parati, who is currently president of the World Hypertension League from Milan, Italy. He's honorary professor of cardiovascular medicine, University of Milano, and scientific director, Istituto Orologico Italiano, and global expert in hypertension, heart failure, and cardiovascular research, president, World Hypertension League, past president, Italian Society of Hypertension, and fellow, European Society of Cardiology. And he has over 1,600 publications with very high index, H index, which is 147, and editorial role in Journal of Hypertension, European Journal of Preventive Cardiology, internationally recognized for research in hypertension monitoring, and various awards that he has been bestowed upon: ESH John Fellow Award 2015, Distinguished Fellow Award ISH, and multiple international honors from AHA, APS, and European Hypertension faculty. Then after that, we have Dr. Brent Egan, who is MD High Blood Pressure, he was member High Blood Pressure Council, American AHA, Greensville, and former Vice President, Cardiovascular Health, American Medical Association, Professor of Medicine, University of South Carolina School of Medicine, and Adjunct Professor, Medical University of South Carolina. And he has leadership, held various leadership positions, former president, ISH, trained in medicine and hypertension, University of Michigan, expertise on hypertension, metabolic syndrome, and vascular disease, over 400 publications, original papers and reviews, and 30 plus years in cardiovascular prevention and health equity. And awards: US DHHS Award 2004, Reducing Health Disparities, Louis Russell Jr. Memorial Award of American Heart Association, Marvin Moser Award for AHA Hypertension Council, So welcome, Dr. Brent Egan. And then we have Michael Weber. Michael Weber has come also with us in the past, and we are very happy to see him back on this hypertension symposium. He's professor of medicine, Sunny Downgrade College of Medicine, University of Sydney. Preventive cardiology, hypertension, cardiovascular risk reduction, major role there. Leader in major hypertension clinical trials and drug development, beta blockers, ARBs, and RNA therapeutics. RNA interference therapeutics, pioneers in ambulatory blood pressure monitoring, contributor to device-based therapy, denervation therapy, then leadership role in founder and past president, American Society of Hypertension, former executive committee member, ISH, board member, World Hypertension League, chairman, Center of Medicine, the public interest, and then academic highlights, over 600 publications, author of various textbooks, and 2014 chair of International Society of Hypertension Guideline Committee, and then former editor-in-chief of Clinical Hypertension. And he is fellow of American College of Physicians, American College of Cardiology, American Heart Association, and consultant to US FDA. So welcome, Dr. Michael Weber. So now I would hand over to our moderator, Dr. Venkatas Ram, to conduct further the meeting and call the faculty for giving their lectures.
Thank you very much, Anil, for the introduction of our faculty. Now, I will introduce the panelists so that everybody is introduced in the beginning and the program flows without pausing for any introductions. I also have to introduce the person who initiated the program, Dr. Anil Parikh, who started the program, who gave the mission about today's program, the World Hypertension Day in connection with, and the theme for this year is controlling hypertension together. Dr. Anil Parikh has extensive experience in medicine and clinical pharmacology. He graduated from one of the best medical colleges in India, Topiwala National Medical College, and then he has experience in case, and he is a person who did a lot of clinical pharmacology trials in various phases for the companies that ultimately, some of them led to the approval by the regulating agencies. One of the few people in the industry that I know has such a strong background in medicine and clinical pharmacology to guide the current and future development of various molecules. In addition to cardiovascular disease, he is also interested in immunological disorders and also on application of novel drugs for the treatment of hypertension. I'm glad that he was able to introduce the program. The one panelist who is going to participate is no stranger to all of us, is Dr. Narsingan, who is current Vice President of the World Hypertension League, and he's the Vice Chairman of the Lipid Association. He held so many senior positions in various organizations, both local, regional, national, etc. And he is known as an excellent teacher and a very good clinician, very astute observer of scientific medical advances, and has contributed to our current understanding of hypertension, not only in the region and in the world. And therefore, please join me in welcoming Dr. Narsingan, who is the current Vice President of the World Hypertension League. His interest in cardiometabolic disorders. Next will be Dr. Debrota Roy, who is a very, very senior cardiologist in not only in Calcutta, in India. He does a lot of organizational work for Cardiological Society of India, a lot of administrative work, which is very important, paperwork. And he also works very closely with World Heart Federation, with which Cardiological Society of India is affiliated with. He's a professor and a senior consultant at Ravindranath Tagore International Center for Cardiac Sciences, Calcutta, where he trains a lot of residents and fellows, and he has worked extensively in clinical cardiology, preventive cardiology. So he has a academic background, clinical background, and I'm also familiar with his administrative background for the Cardiological Society of India. Welcome, Dr. Debrota Roy, for joining us in this year's program. Next is Dr. C.H. Vasant Kumar, who is known to us. He's a current president of the Indian Society of Hypertension. In the past, he was also the president of local and national diabetes societies. He is the founder of a society called Diabetes and You, which supports disadvantaged people afflicted by diabetes. He was the president of RSSDI, well known to us. So he's a cardiometabolic physician. Yeah, and he started, by the way, and I was a witness to it, he started the geriatrics division at Apollo Hospitals, which is the first of its kind. And he still is in charge of the geriatrics clinic. It's very, very important because of elderly people having multiple cardiometabolic and movement disorders. So he's running that clinic also. As I mentioned, he's the current president of the Indian Society of Hypertension. Dr. Jyotirmay Paul, who commented a little bit earlier, he is going to be one of the important panelists. He is very, very closely associated with the Association Physicians from India, where he manages a number of scientific programs for Association Physicians of India. He was the president of API, and he is also managed in an executive position the Journal of Association of Physicians from India, JAPI, which is one of the largest indexed journals, which is physical copies are circulated to so many doctors. It's very unusual now for people to have physical copies, but somehow he made sure that all the practicing physicians in India get the latest JAPI, which is very, very prestigious. He is currently serving as a professor of medicine at Sagar Datta Medical College. It's in Calcutta, but on the outskirts of the Calcutta. It is one of the relatively new government medical colleges in medical education in India. It was established only, as I remember, about 15, maybe 10, 15 years ago. Already it has got all disciplines approved by the National Medical Commission. So he is teaching there, both MBBS, MD students, etc. And he, as I mentioned, he is a master in continuing medical education in various programs in and out of API. Lastly, in terms of my introductory responsibilities, is Dr. Gurpreet Singh Wander, who is a very well-known clinical cardiologist, very well-known hypertension expert, not only in India, but elsewhere. He is currently professor of cardiology and principal, or let us say dean, of the medical college in Ludhiana. He was the president of Association Physicians from India. He was also the president of Hypertension Society of India, and he received the prestigious B.C. Roy National Award by Government of India about 20 years ago. He has a very tremendous interest in not only interventional but also preventive cardiology. And he represents India, by the way, in various Asian networks. For example, he's of Indian representative on the Asian network, Michael Weber, for renal denervation therapy. And some of the renal denervation therapy statements that come from Asian network are in part due to Dr. Gurpreet Singh Wander. And he's a wonderful clinical cardiologist. And every encounter that we have with him is really pleasing. Excellent clinician, excellent doctor, excellent humanist also. With that, I think Dr. Parikh, we can go to the first speaker, Dr. Parati, I think. He has already been introduced.
Yes,
I
yes,
think Dr. Parati can start.
Thank you, Dr. Venkata. I really thank you so much for your invitation. And I'm very happy to share a few minutes with you tonight actually, for your time, to address a very important point which is related to the World Hypertension Day initiative. I hope you can slides. First of all, your meeting is focusing on the need of better clarity. So why do we need better clarity in this field? These are my disclosure, by the way, because we are dealing with a very important problem. You may remember the global report on hypertension published by WHO last year, where it was clear evidence that we are facing with hypertension the most important silent killer in the world. In 2024, 1.4 billion people in the adult age were having hypertension, and only 320 million were controlled. This means huge burden on the cardiovascular system. And we all know that hypertension is one of the main causes for heart attacks, heart failure, stroke, CKD, dementia, and mortality, with a strong impact on socioeconomic cost. Such a high prevalence requires a stronger prevention effort, and we need guidance. There where the guidelines are supposed to help us. But such a high number of people uncontrolled also highlights our systemic weakness in detecting, diagnosing, and managing this condition. You're familiar with this very nice picture describing different regions of the world, different colors. The thick colors refer to the prevalence of uncontrolled hypertension. The thin bars indicate the prevalence of controlled hypertension. This is India. You're not doing worse than other countries, you might do even something better than others, but you also have quite a wide space for improvement, because the prevalence of uncontrolled hypertension is still important also in your country. The World Hypertension League, as you know, is heavily committed to translate guidelines into practice, trying to provide practical implementation of recommendations that might be suitable for different regions of the world. And the main issues that we are supporting as a strategy to improving hypertension control include, first of all, the need of accurate blood pressure measurement with validated and affordable devices. Also, the need of affordable approaches to cardiovascular risk assessment, and the implementation of effective, simple, and again, affordable treatment strategies. This definition also applies to the follow-up. The follow-up, as you know, is one of the difficult parts in hypertension management, where most of our patients are giving up. They're not so adherent as we would like them to be. So we need strategies to improve adherence, also using digital tools, single pill combination, and other solutions. And finally, we need to guarantee an equitable availability of all these possible solutions, drugs and devices. All this has to focus on primary care. Primary care is one of the key situations where hypertension should be faced. It's the front line where we have to identify and manage hypertensive patients. So we need in primary care also to guarantee an equitable access to diagnostics, medicine, and also training of the healthcare force. This is to be done by considering that, as you know very well, hypertension almost never comes alone. So you need to care for multimorbidity and to support, at this level, easy access to diagnostic and therapeutic solutions, strengthening the information system all over the world. So if this is the intention of the World Hypertension League, then how can we work with the guidelines? Well, you may remember we had, in the last few years, 3 guidelines published, the ESA 2023, ESC 2024, and the American Guidelines 2025, that were providing something similar, of course, but also some different indications. They were confusing some doctors. This is where the need of clarity is important. So we came up with a very short paper together with Eugene Young, Doug Nova, Aristi Zabal from Colombia, and myself. We tried to provide an interpretation. And our conclusion is that all these guidelines is true. They follow different roads, but they have the same destination. And I'll try to summarize in these very few minutes what I mean by that. Well, first of all, we need to reconcile to achieve a better clarity the indication they provide us on thresholds, so who should be labeled as hypertensive, question mark. Point number two, how to assess risk, because risk assessment is a key step to decide about medication treatment. Then we need to identify the targets to achieve by treatment. And last but not least, we need to work on the implementation of all this in the long term during the follow-up, avoiding inertia from the doctor's side and improving adherence on the patient side. We have to acknowledge that indeed these guidelines provide some different indication on thresholds to identify hypertension and about the risk engines. But we also need to acknowledge that they converge on the need of accurate measurement, on the need of total cardiovascular risk assessment, on the need of early start of combination therapy, and also on the need to recommend lifestyle changes, not as a light advice, but a structured intervention that should be as much as possible led to application. And finally, we need a structured follow-up. All this starts from the need of a standardized office blood pressure measurement, repeated over time. That's a key point. We cannot diagnose hypertension without a standard approach for measurements. And then we need to use validated devices, a proper cuff size, and repeat this at least over a couple of visits. This has to be confirmed with out-of-office blood pressure monitoring. Home or ambulatory blood pressure are needed to identify what I call the mass hypertension and to confirm the diagnosis of hypertension. Again, this cannot be alone. We need also to add organ damage assessment and identification of comorbidities, and we know very well how important is the risk of damage to the kidney, the heart, the brain, the vessels. Also looking for secondary causes that might help us identify possible reasons that we can remove. So in the end, what we need to do is to identify the thresholds to diagnose hypertension, assess the risk, and decide on patient treatment based on all this. We should not escalate based on just a single casual reading. We need to perform repeated readings. But on the other side, once we have diagnosed and confirmed the existence of hypertension, we should not wait. We should start early treatment, because if you don't start early and you wait until some complication may occur, then you see organ damage, hypertension becomes resistant, and the possibility to go back to normality is much, much less, especially if you have also appearance of organ damage and comorbidities accompany hypertension. And again, follow-up is not something very vague, it's something started since the beginning. We have a shorter follow-up going from the identification, diagnosis, and risk stratification procedure that has to be carried out over a few weeks. And then you have a few months for titration. Then you have the long term. All this has to be structured, providing clear indication to patient to follow a pre-specified pathway. So lifestyle first is a very important indication, but this should not be an excuse for inertia. If you have patients with a pressure confirmed to be equal or higher than 140/90 in the office, then you need to start promptly, not only lifestyle, but also drug treatment. While if you have a blood pressure in the so-called gray zone, where there is some difference between guidelines in the terminology, and this is between 130, 139 systolic, 80 to 89 diastolic, then here you have to follow a overall assessment, including risk assessment. So if you have this blood pressure range plus evidence of clinical cardiovascular disease or stroke, you have to start treatment, no way. The same if you have diabetes, CKD, or if you have assessment of a high level of cardiovascular risk predicted by the different scores. What if you have a lower risk level? Then you might wait a few months waiting for lifestyle changes to produce an effect. But if you don't reach a goal, again, you have to consider starting treatment. There is some difference here between guidelines. The ESC guidelines, if you have this blood pressure range from 130, 39, 80 to 89, allow you to try lifestyle changes for up to 3 months. And then if the cardiovascular risk is sufficiently high after this trial, if you don't reduce blood pressure, you have to start drug treatment. The American guidelines are a bit more interventional. If you have this level of pressure, and then you have a risk according to the PREVENT algorithm equal higher than 7.5%, you start treatment anyway. But even if you are at a lower risk and you cannot reduce this blood pressure level in 3 to 6 months, you should start treatment anyway. So this is the current indication. And as you see in the end, the terminology can be different, but the overall advice is very similar. What about the targets? Again, there is some different wording, but you see a common attitude. The ESH guidelines are proposing for everyone to be below 140 over 90 with treatment, but also lower level below 130 and 80 should be achieved if tolerated. Of course, in high-risk people, you have to focus since the beginning on the lower target, 130 or 80, but they suggest to avoid going too low, no below 120 systolic or below 70 diastolic. And in particular, in older and frail individuals, what you need to do is individualize the approach. The ESC guidelines more or less provide the same indication in different words. They suggest to go below 130, but not below 120. And if not tolerated, also here, they suggest the ALARA principle, as low as reasonably achievable, mainly in the frail people, those with orthostatic hypotension or a reduced lifestyle span. The American guidelines provide an indication to go below 130 for all adults. But again, they also acknowledge that if you have frail people, again, in this case, you need for an individualized approach. So the final suggestion is the target zone for systolic should be individualized based on tolerability, age, diastolic level, frailty, organ damage, and comorbidities. And this is a very strong common message coming from all the guidelines. Just to summarize what are the common principles that all these guidelines are provided us with, every guideline agree on the need of accurate measurement first with validated devices, including out-of-office blood pressure. They suggest a total risk assessment because this is what is guiding the urgency in starting treatment. Lifestyle should be implemented, but not vaguely, very precisely in a structured manner. Drug treatment should be started promptly if blood pressure is equal or higher than 140 over 90 without waiting for complications. And this has to be done using combination treatment, mainly if using single pill combination. This is increasing adherence and efficacy. Targets should be defined based on risk, but also based on tolerability and individualized approach. In particular, beta blockers, that was a controversial issue, are not denied. You can use them when you have clear indication that might indicate the need of modulating the sympathetic activity. Follow-up is very important in the short and the long term because this is what is guaranteeing protection over time. So overall, we need to go for an individualized approach. We start with accurate measurements, identification of risk level, evidence-based individualization of targets for each patient, and then, based on tolerability, deciding about the target to reach. And this has to be guaranteed over time. In our short paper, we came out in the end with a decalogue, and this is just summarizing what I told you, which can be derived from all the guidelines. First, measure accurately, standardized approach confirming with out of office. Second, assess risk using calculators to guide you. Third, set targets, aim for a level below 130 over 90 if tolerated in an individualized manner. Start strong, use single pill combination because this is more effective and faster. Verify adherence, that's very important for the follow-up. Escalate promptly if you're not controlled, not wait too long. We have a few weeks to do that. Then promote lifestyle changes in a structured manner. Monitor what you achieve and co-manage accompanying conditions. And finally, consider also interventional therapy with renal innervation, for example, whenever this is needed. So clear messages coming from all the guidelines. Last year, WHL was proposing for the World Hypertension Day the motto, measure your blood pressure accurately, control it, live longer. This year, we change, we are recommending controlling hypertension together. It's the same message in a different words. And controlling hypertension together means focus on teamwork, combating low awareness worldwide, especially in low and middle-income countries, involving non-medical personnel and supporting digital tools, single pill combination, devices for diagnosis to be used together with our patient that should be educated to collaborate with us. Let me conclude by reminding you that we are organizing for next year the 7th World Hypertension Congress will be May 13 to 15 in Goiânia in Brazil. You are warmly invited to join us. And in this Congress, we will be discussing even more in depth the need for clarity, the need for translating guidelines into effective clinical management. Hypertension remains the state killer. And to improve it, we need adequate control through effective risk reduction that requires early intervention, accurate diagnosis, implementation of lifestyle changes in a structured manner, and personalized, effective drug treatment. Let's work together to reduce the burden of cardiovascular disease worldwide. And thank you again for your invitation.
Thank you, Gianfranco, for really summarizing the goals and importantly aspirations of the World Hypertension League to eliminate the global consequences of undiagnosed, untreated, uncontrolled hypertension. And your remarks are very valuable, and we appreciate your participation. And we will let you know about the discussion regarding your things when you get back. Maybe I'll send you a mail or a message on Monday on any questions that we are not able to answer in your absence. Again, thanks. I learned one new abbreviation today, Gianfranco. I never heard of this abbreviation, ALARA. ALARA, as
Yes.
low as reasonably achievable.
Achievable. Yes, they're used by European Society of Cardiology. You're right.
Well, I have trouble remembering so many abbreviations. Now you added ALARA to my to be done list. Okay, thank you very much.
Thank you. Bye.
Thank you.
Thank you.
We'll move without no questions right now, Narsingan, because Dr. Parati has to go and we'll take his questions later on. We'll go straight away to Dr. Brent Egan's analysis of the current status of beta blockers towards greater clarity. Brent?
Venkata, thank you for the introduction. Thank you for the invitation. I would like to review guideline recommendations for beta blockers in hypertension, cardiovascular, and a few other chronic conditions. Hopefully my slides are sharing. What I'd like to do in the next few minutes is describe the guideline recommended role for beta blockers in managing hypertension, selecting evidence beta blockers in treating and preventing heart failure, implementing beta blockers when indicated post-myocardial infarction as well as later in the post-MI period, briefly to list other indications for beta blockers, including non-cardiovascular conditions, and then provide a summary at the end. The 2025 AHA-ACC guideline actually recommended beta blockers in resistant hypertension. These are patients, uncontrolled resistant hypertension, patients whose blood pressure is 130/80 or higher on 3 antihypertensives, particularly the first-line recommendation of a RAS blocker, calcium blocker, and thiazide diuretic. Notice in the bottom left-hand corner that as a fourth drug, mineralocorticoid receptor antagonist received a class 1 recommendation. In the lower right-hand corner, you'll notice that there were several other medications recommended as alternative fourth-line agents, which included beta blockers with a class 2A recommendation, which is also a strong recommendation. One of the important issues which Dr. Parati raised is the issue of adherence. Obviously, medications don't work if patients don't take them. In terms of strategies for improving adherence,
Sir, you need to
sorry
make
to
the
interrupt you, sir.
slide mode.
I'm sorry.
Full screen, sir. Can you please full screen your slides, sir?
I am sorry if they're advancing.
That's great.
Yeah.
How about now?
So it has not come in PPT. It has not come as a slideshow.
I'm not able to fix it. Are you able to project my slides?
Or you can just I will project
Double
it.
click on that icon, sir.
Fine, sir. I will just do it from my end.
Okay. Hopefully we're able to see this slide. I don't know if the audience was able to see this slide.
Yes, sir, we can.
Okay. And we can go on to the next slide. So as I mentioned, Dr. Parati indicated that patient adherence is obviously important as patients can't benefit from drugs that aren't taken. There were two class 1 recommendations in the 2025 guideline for improving patient adherence. One was the use of single pill combinations, and secondly, once daily dosing. On the left-hand side, you see a number of other class 2A recommendations for improving patient adherence. Next slide, please.
Sachin, can you project the slides? Sachin,
Projecting it.
can you project the slides?
Yeah.
It's not visible.
So now,
Keep a watch on this, please.
yes.
Okay. One of the evidence-based single pill combinations is a combination of soprolol and amlodipine, in this case, 5 milligram of each medication. Notice that the combination lowered systolic blood pressure more than 25 millimeters of mercury. So one possibility would be use a single pill combination of a diuretic and RAS blocker together with bisoprolol amlodipine, providing 4 effective medications in 2 pills, which overall improves patient adherence. Next slide, please. Beta blockers qualify as first-line antihypertensive therapy when indicated for comorbidities. And the comorbidities listed in the 2025 guideline are shown on this slide. We'll focus our attention on post-myocardial infarction and HFrEF, but recognizing that atrial fibrillation, acute coronary syndrome, and women of childbearing potential also have indications for beta blockers. Next slide. There are 3 beta blockers recommended in patients with clinical heart failure with reduced ejection fraction, or HFrEF. Those 3 beta blockers are bisoprolol, carvedilol, and metoprolol succinate. Next slide, please. The three beta blockers mentioned, bisoprolol and CBUS2, metoprolol succinate merit heart failure, and carvedilol and Copernicus all reduce mortality by about 1/3. Notice that bucindolol, a drug with intrinsic sympathomimetic activity, which is less effective reducing heart rate, did not provide a significant mortality benefit. Next slide. In studies that looked at beta blocker and non-beta blocker therapies in heart failure, there was also a relationship between the lowering of heart rate and fewer cardiovascular events and the increase of heart rate and more cardiovascular events. The benefit of reducing heart rate include reduced myocardial oxygen consumption, prolongation of diastole in which coronary blood flow occurs, and improving calcium uptake by the sarcoplasmic reticulum during diastole. Next slide, please. This slide indicates the beta-1 selectivity of various agents. Notice that bisoprolol has greater beta-1 selectivity than betaxolol, atenolol, and metoprolol. And in studies of reactive airways, patients with reactive airways disease and metabolic abnormalities, greater beta-1 selectivity had clinical advantages. Next slide, please. The drugs commonly used to treat stage C heart failure, symptomatic heart failure, HFrEF, include bisoprolol, carvedilol, and metoprolol, as we noted. Starting doses are noted in the second column and target doses in the middle column. Without going through these specifically, target doses are not always achieved. However, if patients are on less than target doses but achieve good heart rate control, they obtain the clinical benefit. So the key appears to be good control of the heart rate. Next slide, please. The ability of the various evidence-based therapies for preventing death over 3 years was examined and reported also in the 2025 Heart Failure Guideline. I'd like to call your attention to beta blockers, where treating 9 patients with HFrEF for 3 years prevents 1 death. 1 death in every 9 patients treated with beta blockers and HFrEF over 3 years. Clearly impressive, important finding. Next slide, please. Interestingly, in the guideline for heart failure, beta blockers are also recommended for preventing clinical heart failure in patients with structural heart disease, but no clinical symptoms of heart failure. So again, preventing clinical heart failure in these patients, beta blockers have a class 1 indication for reducing mortality. Next slide, please. What I'll do in the next couple of slides is present some conflicting evidence for the value of beta blockers after MI with ejection fractions of 40% and higher. In the reboot study, patients were randomized to beta blockers, mainly bisoprolol, within 2 weeks after an acute MI with an left ventricular ejection fraction of 40% or higher. The primary outcome was all-cause mortality, reinfarction, and heart failure hospitalization. After a mean follow-up of 3.7 years, there was no significant difference in outcome between those that received beta blockers and those that didn't. And in fact, those results are shown on the right-hand side. Their conclusions were in patients discharged after MI with EFs of 40% and higher, beta blockers did not impact all-cause death, reinfarction, or heart failure hospitalization. Next slide, please. In additional studies, beta MI and DAN block, patients were also randomized to beta blockers, metoprolol, bisoprolol, carvedilol, nivolol, after an MI with ejection fractions of 40% or higher. Again, randomized either to beta blocker or no beta blocker. The composite all-cause outcome was death or MACE. And MACE had more items in it than the previous study: new MI, unplanned coronary revascularization, ischemic stroke, heart failure, or malignant arrhythmias. After a mean follow-up of 3.5 years, the primary endpoint occurred in 14% of patients not on beta blockers, or on beta blockers rather, and 16.3% not on beta blockers. So a benefit for beta blockers with a 15% reduction, which was statistically significant. So again, the conclusion is patients with MI, left ventricular ejection fraction of 40% or higher, beta blockers are clinically beneficial. Next slide, please. There was then a meta-analysis which attempted to reconcile the findings. In fact, the findings were reconciled. So the 4 trials, including Reboot, which did not show a significant effect, the analysis restricted to patients with left ventricular ejection fractions of 40 to 49%. Notice in these patients over an average of 3.5 years, the patients on beta blocker had a 25% lower risk of acute MI, all-cause mortality, and heart failure. If you look at the hazard ratios for the individual trials, they're actually quite similar. So when the ejection fraction was restricted to those with 40 to 49% post-MI, there was a benefit of beta blockers. The study on the right looked at continuing beta blockers after MI in patients with ejection fractions of 40% or higher. These patients had already been on beta blockers an average of 3 years. The patients were followed up with an additional 3 years of beta blocker, no beta blocker therapy. It was a non-inferiority trial, but it was not a non-inferiority outcome. In fact, those that received beta blockers had fewer death, MI, stroke, or cardiovascular hospitalization. A subsequent analysis of those with LVFs of 50% or higher showed no benefit in terms of the long-term outcome. But again, the 40 to 49% group, both in the first 3 years and the subsequent 3 years, showed benefit. Next slide, please. The European 2023 ESH guideline provided a number of indications for beta blockers with clinical conditions, one being hypertension with an elevated resting heart rate of 80 or higher. A number of trials showing that resting heart rates in patients without prior cardiovascular events have higher risk of cardiovascular events and sudden death. However, there are fewer trials showing that beta blockers are beneficial relative to other first-line therapies in that group of patients. Some of the other conditions noted were portal hypertension with esophageal bleeding, where beta blockers can be beneficial, hypoparathyroidism and uremia, migraine headache, and essential tremor. Next slide, please. My slides are particularly challenging. I don't know what I did in putting them together, so thank you for bearing with us here. Okay, so the next slide. Okay, this was the recommendation of the 2025 guideline around use of beta blockers in the perioperative period. Notice in the lower left-hand panel that patients on beta blockers should continue them through the perioperative period, which was a class 1 recommendation. Also, that the beta blocker should not be abruptly discontinued, class 3 harm, and that beta blockers should not be started on the day of surgery in beta blocker naive patients, again, class 3 harm. Next slide, please. So to summarize the presentation, beta blockers are indicated as the 4th drug in patients with treatment-resistant hypertension as an alternative to mineralocorticoid receptor agonists. Bisoprolol, carvedil, and metoprolol succinate are recommended for treating and preventing heart failure, particularly in patients with reduced ejection fractions. In patients with acute MI and ejection fractions less than 50%, early initiation and maintenance of beta blockers for 3 to 6 years reduce death and MACE. And other indications for beta blocker include resting heart rates of 80 and higher, although evidence for primary prevention is limited. There are, as we noted, multiple non-cardiovascular indications for beta blockers. I appreciate the opportunity to present this data and look forward to questions during the discussion session.
Thank you, Brent. Appreciate your summary of somewhat of a complicated topic. Then we have one of the panelists who will come later on, who will comment on your talk. Each panelist will comment on individual talks, and Dr. Wander will comment on all the talks together.
Okay.
Okay, now I'll start. Ladies and gentlemen, my responsibility is, as the theme is towards greater clarity, one of the interesting things with older drugs has been with diuretics. Diuretics have been around for a long time for the treatment of hypertension, although the mechanism of action is not completely understood. But all the guidelines, whatever guidelines you look at it blindly, they have always included a diuretic in the treatment of hypertension, either as monotherapy or as a part of combination therapy. One debate that has been very pervasive in the last 50 years has been whether it is hydrochlorothiazide or chlortalidone, which is a preferred diuretic. A number of meta-analyses have compared individual trials, but more recently, a direct comparison has been made for the first time. So once the direct comparison has been made, I think now the debate over the controversy appears to be receding due to 2 or 3 studies published recently, and I'm going to share with them. Low dose chlortalidone, believe it or not, has been approved by FDA only last year. We had chlortalidone for a long time, but low dose chlortalidone was approved in about exactly 1 year ago because FDA felt that physicians in US were not using chlortalidone at the doses that are available, like 20 or 50 milligram, because of the fear of electrolyte disturbances. So they went back and looked at some data showing that low dose chlortalidone is as effective as standard dose, while you don't see any side effects. So suddenly, on May 7th last year, FDA approved low dose chlortalidone for the treatment of hypertension. And Dr. Billy White, who was part of the people who presented to FDA, thought that this will allow additional flexibility for US physicians to take advantage of low dose chlortalidone, which has been available in other countries like India for a long time. The last set of guidelines from US, the last American Heart, American College of Cardiology, they have used the word for the first time, thiazide type diuretics. If you look at all the guidelines in the past, they said only thiazides, but this one, because of the release of low dose chlortalidone, they use the phrase thiazide type diuretics, and they have suggested the diuretics that are available and that can be used in the treatment of hypertension and the dosages. And these are the most recent American Heart Association ACC guidelines. I mentioned to you earlier the mechanism of action of diuretics in the treatment of hypertension is not 100% understood. It is certainly not due to volume depletion. It is not due to continued natriuresis. And this is a study that was done by one of the doyens in cardiovascular therapeutics, Dr. Tarazi, who showed that when you give a diuretic, the blood pressure does come down. Ultimately, the plasma volume becomes normal and the cardiac output becomes normal, but the peripheral vascular resistance remains lowered. So he suggested that the mechanism of action of diuretics is due to a fall in peripheral vascular resistance and not due to a reduction in plasma volume or cardiac output. In other words, it is acting just like any other vasodilator. Very interesting phenomenon to keep in mind, that the dominant mechanism of action of diuretics is vasodilatation and not continued natriuresis or volume depletion. This is a study that myself and Dr. Kaplan, late Dr. Kaplan, my associate, did a long time back, looking at the effects of different diuretics on blood pressure. This was not an outcome trial. This was just a trial to look at 24-hour effects on blood pressure. And at that time, we noted that chlorthalidone, because it was a long-acting drug, was a little bit better than hydrochlorothiazide for control of hypertension. But this was not an outcome trial. This was just mainly looking at blood pressure as a surrogate. Dr. Kaplan wrote this editorial sometime back. It was a very, very popular editorial, Chlorthalidone versus hydrochlorothiazide, a tale of tortoise and a hare. So what the conclusion was, although out of the two, tortoise and hare, it's the tortoise chlorthalidone what was slow but steady instead of being erratic and very fast like hare. And this editorial prompted renewed interest in chlorthalidone for the use in hypertension, either alone or in combination with other drugs. Two recent papers in the recent past have given an answer to which diuretic between chlorthalidone and hydrochlorothiazide might be superior choice for the treatment of hypertension. And this is a study that is called Diuretics Comparison Project. First study to compare head-to-head hydrochlorothiazide versus chlorthalidone. Previous trials either compared them individually or the drugs were switched, but not head-to-head. And this head-to-head comparison was done in US by a variety of investigators belonging to Veterans Administration hospitals. The main paper was published as a lead paper in New England Journal of Medicine, and sub-analysis were published in JAMA Cardiology. And both these papers now appear to have erased the debate on which diuretic among the two is a superior choice for the treatment of hypertension. In the diuretic comparison project in the main paper, they compared the events between hydrochlorothiazide 25 milligram and chlorthalidone 12.5 milligram. You notice the percentage of events was very similar at lower dose of chlorthalidone compared to standard dose of hydrochlorothiazide. And the conclusion was there were no differences in any components of primary outcome. When you look at normal dosage of hydrochlorothiazide and low dose of chlorthalidone, in this paper, the effects on blood pressure were exactly superimposable, and the effects on potassium were superimposable. One moral that you can draw from this study was, at low dosage that is now currently recommended, one does not see too much of potassium wastage. The potassium wastage or hypokalemia was mainly a feature of high-dose chlorthalidone therapy. But in the diuretic comparison project, when low-dose chlorthalidone was used, the effects on potassium were similar to that of hydrochlorothiazide, and the effects on blood pressure were also very similar. When you look at patients with primary outcomes. When they looked at the primary outcomes, namely heart failure, acute myocardial infarction, and stroke, acute kidney injury, they were significantly lower in the chlorthalidone group compared to hydrochlorothiazide at the same level of blood pressure. That is the key, at the same level of blood pressure. A sub-analysis was done in patients with pre-existing cardiovascular disease from the study, and they noted that the primary events were lower in the chlorthalidone, and the incidence of heart failure was significantly less. So one conclusion of this sub-analysis was, in patients with prior cardiovascular disease, namely any patient with hypertension, the outcomes were significantly better in the group that was exposed to chlorthalidone compared to the group that was exposed to hydrochlorothiazide. When they looked at acute myocardial infarction, it was significantly lower in the chlorthalidone group compared to hydrochlorothiazide. Like all other major trials, they looked at non-cancer deaths. They were lower in chlorthalidone, but one cannot comment on this because the patients were not pre-screened for cancer. So this was just only an observation that is generally in most of the cardiovascular studies. When they looked at the adverse effects, very similar. Hyponatremia incidence very similar. Hypokalemia incidence was very similar. So one important revelation is that low dose chlorthalidone, normal dose hydrochlorothiazide, the side effects were very similar, but the benefits on cardiovascular disease prevention, primary and secondary, were greater in the chlorthalidone group at the same level of blood pressure. One observation that I made from this paper, and the letter to the editor was not accepted, is that patients were on chlorthalidone for a shorter period of time compared to hydrochlorothiazide. So I had written in that letter where the shorter duration of chlorthalidone was as good as a longer duration of hydrochlorothiazide. We do not know that, but very interesting observation. And as I mentioned, the letter was not accepted for publication. So, ladies and gentlemen, and Dr. Parikh, one of the conclusions from the JAMA article is that chlorthalidone may be associated with fewer adverse cardiovascular events compared to hydrochlorothiazide. These are the other large trials that were done with chlorthalidone during our lifetime. A variety of studies have used chlorthalidone by itself or in combination. The latest study is, of course, SPRINT, which used chlorthalidone in combination with other drugs. But the studies that are shown in trial are well known to you and have been published for many years counting, but they were not comparing two diuretics. They were individual drugs. So FDA, after so many years, chlorthalidone was approved in 1960, but just last year they approved low-dose chlorthalidone. There is one trial that I want to show, which is of interest to patients who treat chronic kidney disease. It has been said before that thiazide-type diuretics are not effective in patients with chronic kidney disease. But Dr. Agarwal, Rajiv Agarwal and co-workers, this study in patients with chronic kidney disease New England Journal of Medicine. What Dr. Agarwal and co-workers have shown is in patients with chronic kidney disease, chlorthalidone lowered the blood pressure quite effectively, which is a new finding. This has not been shown before. When they stopped the drug, the blood pressure went up again. So it's a very interesting observation from the CLIC trial. they also showed that proteinuria decreased significantly in the hydrochlorothiazide group compared to hydrochlorothiazide, suggesting indirectly that it could be an effect on blood pressure rather than a direct renal effect. And when they stopped the drug, again, the proteinuria went back. So very important monumental trial, click trial, that adds to the scope of the use of chlorthalidone in patients with hypertension and comorbidities. Very interesting trial. Dr. Parikh, who introduced the program, did this trial using low-dose chlorthalidone with standard doses of hydrochlorothiazide. The study was published in the Journal of American College of Cardiology. Unbelievable, almost 10 years back, showing that low-dose chlorthalidone controlled the blood pressure as well as normal dose hydrochlorothiazide using 24-hour blood pressure monitoring. So Dr. Parikh, ladies and gentlemen, the debate over the choice of diuretics in hypertension is over finally. Some clarity has been provided by the diuretic comparison project, and then looks like, based upon the recent FDA approval as well as the guidelines recommendation, there appears to be an important option in the management of treatment of hypertension, as it has always been since the guidelines were formed. But the debate appears to be fading with more and more accumulating evidence. And I have discussed some, and there are other trials that are also coming up. So with that, I will conclude, and then we will go on to the final talk, but an important talk by Dr. Michael Weber, because everybody asks, what about the role of ARNIs? Cardiovascular drugs, very highly recommended for patients with heart failure, but a very frequent question has been, what would be the emerging role of ARNIs in treating hypertension? And for this, we have asked Dr. Michael Weber, who follows the drug development story constantly. He's been on the forefront of drug development for more than 5 decades, and he's always looking at the radar of what might be emerging in hypertension therapeutics. So we have asked him to speak on this, and we are fortunate that he has accepted to give his commentary on the emerging role of ARNIs in treating hypertension. Michael?
Okay, thank you, Venkata, and I hope you can all see my first slide.
Yes.
But excellent. Incidentally, Venkata, before I talk about this, one very quick comment on what you just so wonderfully presented about the diuretics and chlorthalidone is very relevant to India, more so than here in the States, because in India you have so many drugs available where chlorthalidone in a low dose is part of a combination therapy. Here in the States, we are very limited in that respect. And so India is well ahead of us in being able to use the excellent data you just presented about the diuretics. But okay, let's talk about angiotensin receptor neprilysin inhibitors, ARNIs, which is another abbreviation, which isn't too well known right now because these drugs, other than for the treatment of heart failure, are not that widely used. So let's go on and see what's going on and where potentially we might go. ARNIs actually began about 25 years ago. The concept of combining a blocker of the renin-angiotensin system, and back then the ACE inhibitors were basically the only available agents, with an agent that enhanced the availability of natriuretic peptides. And for those of you not familiar with natriuretic peptides, these are naturally occurring peptides in the wall of the heart, in the brain, perhaps other tissues as well, that have the ability to enhance sodium loss, but also have anti-proliferative, anti-inflammatory effects in the heart wall and other key organs. So what a wonderful idea to combine a blocker of the renin-angiotensin system with increased availability of natriuretic peptides. And how you increase the availability of natriuretic peptides? You give an agent that prevents these natural substances from being degraded. And we now know that's a hormone called neprilysin. So if we can block neprilysin, we make available these very important drugs that we already have on board. Didn't go too well at first because the ACE inhibitor, as some of you may remember, can sometimes cause the problem of angioedema, and the neprilysin can also enhance that effect. So no one wanted to use a drug that was going to cause angioedema. The good news is that now, in combination with an angiotensin receptor blocker rather than an ACE inhibitor, we have a very exciting combination. These are some of the benefits we would get by adding the neprilysin inhibitor, and it's very simple. Let's start at the top. We get more diuresis and natriuresis. We reduce salt sensitivity. We reduce sympathetic activity. Therefore, we reduce vasoconstriction. The effects on the heart wall, we reduce left ventricular hypertrophy. Very importantly, we reduce cardiovascular fibrosis, reduce arterial stiffness, and even inhibit the renin-angiotensin system to some extent. In other words, all the things that seem central to improving not only blood pressure control, but cardiovascular could result from the use of this combined therapy, the blocker of the renin-angiotensin system, plus the ability to increase our natriuretic peptides. Okay. This is a look at a meta-analysis of studies where an ARNI, one of these combinations I've just described, are compared typically with an ACE inhibitor or more usually now an angiotensin receptor blocker. Are they more effective, or is the combination more effective than just using the angiotensin receptor blocker alone? And particularly the question is, how often are we able to get patients down to less than 130 millimeters of mercury, which, as you know, is the target in the United States? And the answer, very simply, about 80% improvement in getting to target if we use the ARNI combination rather than just the ARB. And if we look at adverse effects, just to make sure there's nothing happening that we didn't expect and didn't want, here there's quite a big meta-analysis, and we see, if you look at the odds ratio of just, again, the comparison between the ARNI, the combination, versus just the ARB, no difference in adverse effects. So we can be reassured that this is a very safe combination. Okay, good news. What about the blood pressure effects? And this is a fairly recent study by Dr. Wang and his group mainly in Shanghai, in China, published in the Journal of Clinical Hypertension, and comparing which is sacubitril, which is the drug that prevents the breakdown of our natural peptides, that are natural natriuretic agents, combined with valsartan. So sacubitril, valsartan, which many of you are thinking, oh, wait a minute, that's the drug we're supposed to use for treating heart failure. And the answer is yes, it is. We'll get to that in a moment. But just looking now at blood pressure, we see that the sacubitril valsartan versus just a blocker of the renin-angiotensin system, it was clearly more effective in reducing systolic blood pressure. The difference here for the systolic blood pressure is quite significant and quite large, about 7-8 millimeters of mercury. So good news, we definitely get a clear blood pressure reduction benefit from using this combination. Here is a comparison done in Japan, published in Hypertension Research, which is the official journal of the Japanese Society of Hypertension. And what we're looking at, if we look here at the left side of the slide, the light blue is the low dose of sacubitril valsartan versus a slightly higher dose. Both very robust reductions in blood pressure, about 20 millimeters of mercury reduction in systolic, clearly more than with olmesartan. And let me remind you that olmesartan is one of the most powerful of all the angiotensin receptor blockers. So to be able to beat olmesartan this easily really is a very, very important finding. It's interesting that the difference in diastolic pressure isn't quite as much. Why is that? It's very simple. When you have an agent such as the sacubitril and the natriuretic peptides now able to do their job, you get some naturally occurring diuresis, and you, in a sense, are doing what a diuretic would normally do. So you don't get so much of a reduction in diastolic blood pressure. But I think my colleagues in this program, both Brent Egan and Venkata, and unfortunately not anymore Gianfranco, who had to leave, would agree that the hardest part of treating hypertension is to reduce the systolic blood pressure. That, in a sense, is what it's all about. Here, a similar study, now looking at 24-hour blood pressure data, and which most of us recognize now is the most important way of looking at blood pressure, because we are very concerned not just about what's happening during the day, where we see patients in our offices or clinics, but also what's happening at night. And we see, compared with this light blue color, which is olmesartan, we see that the slightly different doses of the ARNI, the combination of the sacubitril and the valsartan, is again clearly superior for the 24-hour period, during the daytime period, and very importantly, during the nighttime period. Remember, it's the nighttime blood pressure more than any other time of day. It's the nighttime blood pressure that is the strongest predictor of cardiovascular outcomes in hypertension. So this is really very valuable and relevant information. Now, please excuse me for this slide. It's a little bit hard at first to understand, but it explains why there's a lot of enthusiasm about this combination treatment as far as the kidney is concerned. And if we look here at normal situation in hypertension, we can call it glomerular hypertension because that's the natural state in hypertension. We see that there is an increase in pressure within the glomerulus. The afferent arteriole is dilated. The efferent arteriole is not particularly changed. And what happens is we see an increase, therefore, in glomerular pressure. And what we see on this line underneath, this is the number of capillaries that are being infused in the kidney through the glomerulus. And we see only about half of the available capillaries are getting perfused in hypertension. If we give an ACE inhibitor or an ARB by itself, we increase the pressure in the efferent arteriole. We decrease the pressure in the efferent arteriole, and that has the effect of reducing glomerular pressure. So we get less filling of the capillaries, and we don't increase the number of capillaries that are being perfused. So the net effect, and we see it all the time when we give an ACE inhibitor on ARB by itself, initially, you actually get an increase in creatinine because for this reason, we are decreasing perfusion of the kidney. Luckily, after a few weeks, that comes back to normal, but still interesting. With the ARNI, with the combination of the natriuretic peptide increase caused by the ARNI, as well as the blocking of the renin-angiotensin system, we equalize the glomerular pressure, eventually decreasing it slowly. And guess what? Now 100% of capillaries, or close to 100%, are allowed to participate and therefore enhance kidney function. Well, with all of that said, let's look at some real clinical data. And it comes from a heart failure trial, but that's good because what things happen in heart failure are a very predictive thing for seeing what's going to happen with hypertension. So here in heart failure, sacubitril valsartan, which is now, as you know, a required treatment for heart failure, not just a suggestion, but required, we see that compared just with valsartan, the ARB by itself, if we look at the proportion of patients who have a more than 50% deterioration in their ejection fraction, a more than 50% reduction in ejection fraction, we see that compared with valsartan, the patients getting the combination, the ARNI, the sacubitril compound, that number is reduced by about half. In fact, exactly 50% reduction in deterioration of kidney function. And if we look at change in eGFR, glomerular filtration rate, again, a highly significant difference favoring the use of sacubitril with the valsartan. Sacubitril doesn't just improve blood pressure control, it dramatically enhances protection of the kidney. That is huge. Okay, what about heart failure? We all know how good this drug is in heart failure, but it's the same story we just saw, no matter what endpoint we look at in heart failure. Cardiovascular death, heart failure, hospitalization, all-cause death, first and recurrent hospitalizations, everything you can think of, but particularly cardiovascular death, are significantly decreased. My only comment is, well, we know this already about heart failure. My comment is, as heart failure goes in terms of outcomes, so does hypertension. They are a continuum of the same disease. And I am very confident in speculating, and a very strong speculation, that we would see these benefits in treating high-risk patients with hypertension. So here's my last slide. And let me start off by saying, obviously, that these ARNIs, the combination of the drug, of the agent that allows our naturally occurring natriuretic peptides to be increased in our blood, ARNIs have a very useful blood pressure lowering effect, superior just to the monotherapies with the ACE inhibitors. The benefits anticipated 20 years ago, when we started working with a drug that didn't work out because of the side effects, have now been confirmed by studies in hypertension, heart failure, and chronic kidney disease. And so now we're able to say the non-blood pressure effects of ARNIs on the heart, the kidneys, and on what we might call neuroendocrine modulators, not just the renin-angiotensin system, perhaps also aldosterone, should provide important outcomes benefits for patients treated for hypertension. And again, let me emphasize that dual blockade of neprilysin and angiotensin receptor blockers, not ACE inhibitors for safety reasons, but just using angiotensin receptor blockers as the combined factor with neprilysin is going to give us very interesting and I think exciting opportunities for treating hypertension in the future. Venkata, let me stop there.
Thank you very much, Michael, for giving an insight into a compound that is not 100% new, but it will be new when it is approved for hypertension. and I will have other people comment on it. We have one commentator for each talk, and he will comment further. I want to mention something. When you recognized Asia and India in particular for developing low-dose clothalidone, one should not forget the development of antihypertensive therapy with reserpine. With reserpine started also in
How much
India.
time will it take?
Yeah. Okay. Now I would like to have Dr. Narsingan comment briefly on Dr. Parati's talk.
Yeah, thank you very much, sir. And Dr. Parati, I think he delivered in a great talk, summarizing the important concepts which were obtained from various academic bodies' recommendation in the form of guidelines. He started with the 2023 guidelines where the threshold to make a diagnosis of hypertension is different. In 2024, it is different, and 2025, again, it's different. Whatever is the threshold that has been advocated by all these guidelines, finally the destination seems to be the same. Reaching the goal of less than 130 over 80 is the one that is universally accepted. And most of the guidelines have agreed to this particular goal for most of the patients. And he also had mentioned that people in whom you have blood pressure of 130 to 139 systolic and 80 to 89 diastolic, these patients probably require, if they have a high risk, they require pharmacotherapy as early as possible. And in case these patients also have an underlying heart disease or ASCVD, they require pharmacotherapy. But in those patients in whom you don't have any sort of target organ damage or no other higher cardiovascular risk, by using the prevent calculator or other calculators, if he is not a high risk individual, probably we can even wait for these patients to get into the lifestyle modification for a period of 3 to 6 months maximum, at the end of which, if you are not able to reach this goal, probably they also need the pharmacotherapy. And they were very clear in telling us that anything that goes beyond 130 systolic need to be addressed as early as possible, depending on the situation what the patient is facing. For example, if he has got a high risk individual with a more than 130, he needs treatment after lifestyle modification. If it's already underlying disease like diabetes or a problem of like CKD or an already established thoracic cardiovascular disease, he requires pharmacotherapy as early as possible. But never wait for patients to go beyond 140/90. That requires immediate pharmacological management. That is what he had mentioned. Whatever is the threshold that has been recommended by various academic bodies, finally they converge to tell us the important goal in reaching the patient, in reaching this particular goal of 130/80 for most of the cases. That is a comment what I thought I should give it.
Thank you, Dr. Narsingan, for your observational commentary on Dr. Parati's talk. Now I would like to ask Dr. Debabrata Roy, who is, this is his field, cardiovascular medicine, to comment on Dr. Egan's talk, because Dr. Roy has so much of experience in clinical medicine, and now with the current institute in Calcutta, which is associated with Narayana Hridayalaya also. So his comments will be most welcome. Debrata.
Yeah. First of all, Dr. Egan, thank you very much for giving this talk on beta blockers, because in India, beta blocker is a widely prescribed antihypertensive, especially in the rural cohort and also among the young hypertensives. In fact, we have done a survey on more than 8,000 young patients, and we have seen that, to our most surprise, that beta blocker has been prescribed as a single initial agent in about 32% of the young population and stands only second to ARB. Now, you have covered very nicely all the facets regarding the beta blocker therapy as an antihypertensive. Only I wish to comment on the issue of stroke with the beta blockers. We know that the beta blockers has not been favored for a long time till the ESH 2023 guideline because of the stroke, risk of stroke. But the recent meta-analysis, they have found that the stroke risk with beta blocker may be overemphasized and may not maybe similar to other agents like the ACIs, ARBs, or diuretics. And the very fact that we now have very highly selective beta 1 blockers and the recent trend or the recent guideline for prescribing a combination. So we can always combine a highly selective beta 1 blocker with a calcium channel blocker, which can be used widely. This is very important because such combinations, we have often found that they are more, they're less costly as compared to other combinations. And this might have an important implication in future control of hypertension in India. Thank you. Dr. Ram, sir, you are muted.
Okay, we all make this day. Deborah, thank you for your observational commentary on Dr. Egan's talk, because Dr. Egan himself, for a long time, worked on the role of sympathetic nervous system as an individual investigator, as well as with sympathetic nervous system maestro, Dr. Steve O'Julius. So he comes from that background, from that genetic background of sympathetic nervous system and hypertension. Now I'll ask Dr. Vasant Kumar, the president of Indian Society of Hypertension, to comment on my talk.
Okay, so I can understand that I need to be very brief, but it's wonderful listening to these legends on the management of hypertension, and then coming to my own boss, Dr. Ram's topic on diuretics in hypertension. Surprisingly, as he mentioned, diuretics have been there for many decades, and they continue to be very effective, useful, as he stressed. Either you're treating hypertension when it's alone or when there are comorbid conditions where it can be very safely given. You mentioned very well about using it in cardiovascular disease or CKD. And the most important thing that you mentioned, sir, is about the advantages between the hydrochlorothiazide and the chlorthalidone, certain advantages that we can take at whatever dose we are giving. But I think it's an eye-opener for many of us that if we are not using it adequately, we need to use it either alone or in combination. So thank you for giving us that enlightening talk. Thank you.
Thank you. Now, by the way, I want all the faculty and panelists to be there because I saw already some questions. We'll manage as many as possible. Now, the light that was shed on ARNIS by Dr. Michael Weber is further going to be lit by Dr. Jyoti, my Paul Jyoti Light. His name itself is Light. So he is going to shed light on Dr. Weber's talk.
Thank you. We are very much delighted to have a talk from Dr. Michael Weber. In ICMR study, it has been observed that 1/10 of the rural population and 1/5 of the urban population is proper hypertension control. This is not due to the high salt intake among Indians or poor drug compliance. This is basically due to the diverse pathophysiology of the hypertension. So we have to treat hypertension not only with the traditional drug, we have to explore the newer ways, the other drugs which can control or take care of the different pathophysiological process that is responsible for high blood pressure among Indians. Also, hypertension does not mean the numerical reduction of the blood pressure. We have to take care of the organ damage also. From that viewpoint, ARNI is becoming very promising. Initially, it was discovered as a drug of hypertension, but it is basically established as a drug of heart failure. But in the subsequent studies, meta-analysis, all have shown that the sacubitril valsartan combination is better than the olmesartan or olvalsartan when we are treating alone. That means when we are treating hypertension only with ARB, but if we combine ARB with sacubitril, effect is more, particularly from the remodeling of the different organ, particularly the left ventricle. So this combination is very promising for the 24 hours BP control, particularly the nighttime BP control, and it is very important because the morning surge is responsible for the cardiovascular catastrophe, even for the CKD patients, for the elderly hypertension, and difficult to treat hypertension. In 14 meta-analysis, when meta-analysis done with the 14 studies, it has been shown that ARNI is promising for stage 1, stage 2 hypertension. So some of the countries, Japan, China, they have already recommended ARNI as a therapy for the hypertension and more beneficial than using the monotherapy with ARB. So I hope with further study, even in India, is very much needed with the ARNI, whether this drug is more effective in controlling hypertension and preventing the mortality and morbidity out of hypertension. Thank you, Dr. Ram, for taking such a beautiful initiative. Thank you.
Thank you, Jyoti. I know that your remarks not only represent your vast knowledge on hypertension, but you also represent a major organization. So that's why it's very, very important on this developing compound. Now I will ask Dr. Wander, the virtuoso of cardiovascular disease in India, to give his overall remarks on all the 4 talks. Gurpreet? Dr. Wander there somewhere? Sachin?
It's not seen.
I thought I saw him, right?
Yeah.
Hey, he joined.
Yes, it joined, sir.
He joined, okay. Maybe he got out. Maybe does he have to re-log in or what?
Just a minute.
What we can do?
Take up the question.
Yeah, let's do that because it's later the thing.
Yes, sir.
Now, the question, anybody can answer. If there's anybody specific, I'll also ask. Just hold on. I'm just scrolling this up. There is a question from, I hope I'm, okay. There is a question from Dr. Samir, whether these broad effects of chlorthalidone are related to carbonic anhydrase inhibition or antiplatelet effects. They are useful, but it's hard to separate when something lowers the blood pressure. When something lowers the blood pressure, these other effects are important. How much they're contributing will be very difficult to isolate, like any other pleiotropic effects of statins, for example. When you lower the lipids, the pleiotropic effects, what they mean is not known. Then Dr. Michael, although you did not cover accomplished trial, that was not intention. Do you comment on accomplished trial and in the context of chlortalidone which was not used? Because I know that you have done, I'm asking you because you have done the analysis of the accomplished trial.
Yes, yes. That's an interesting question because after we published the accomplished trial in the New England Journal of Medicine, some of the what you might call die-hard diuretic people who really thought diuretics should always be the first drug for treating hypertension, said, well, you studied the wrong diuretic. You showed that adding amlodipine to a blocker of the renin-angiotensin system was better than adding hydrochlorothiazide. But if you'd have used chlorthalidone, it would have been different. Well, that's not right. I suspect it would have been exactly the same. And one of the things that we learned and accomplished, and I'm reminding you of these data, Venkata, because it's a while since they were presented, if I recall correctly, at the American College of Cardiology a few years ago. What we learned was that the diuretic therapy, and this was, by the way, seen in other chlorthalidone trials. Chlorthalidone was very effective at reducing cardiovascular outcomes in obese people, reasonably effective in people who could be called overweight, and not very effective in people of normal weight. So that diuretics are best in people who are obese, who I assume have much larger plasma volumes, much larger overall volume going on, and therefore perhaps better targets for a diuretic therapy. But in overweight people and thin people, they are not as good as using a calcium channel blocker.
Thank you. There is a very good, not a question, but a wonderful comment. I can't say from whom. It is important to have a collaborative approach from Cardiological Society of India, Dr. Roy, Dr. API, maybe Dr. Paul, and Indian Society of Hypertension, Dr. Vasant Kumar. They feel that if all the three societies can give a common statement, if not guidelines, common statement, position statement, that will be very useful. Especially Debrata, you're an expert on position papers. So
Yeah.
it's a very good comment to have different.
Yeah, that's a very good idea. Of course.
Yes, sir. API, CSI, and Indian Society.
Yeah.
We'll work on it.
Okay.
Yeah.
This is a comment from somebody. And then Dr. Narsingan, the question always comes up, but usually it is hypothetical. By the way, others can also comment on goal blood pressures. What if the systolic blood pressure is 100 in somebody age 55 as a result of therapy? Question always comes up.
Yes, sir. If you're reducing the systolic blood pressure less than 130, you can go up to up to 120. 120 to 129 is the safest zone when the patients will become comfortable. If you are going to reduce it less than 120, there are few studies which are going to show aspirin trial, the BP road trial, all those trials have shown that the blood pressure reduction below 120, reaching up to 119, 118, also these patients, they do very well, and the cardiovascular events will also come down. So at present, we are not in a position to accept that these patients' blood pressure need to be brought down to these levels. We need to keep their levels between 120 to 129 systolic and less than 80 diastolic, preferably between 70 to 80 diastolic. That is the ideal one. The diastolic blood pressure should not be brought down below 70 because it's like to probably precipitate the cardiovascular problem, particularly the coronary artery disease worsening. So I think we should not be in a hurry or aggressive approach to bring down the systolic blood pressure to the levels of 100. If the patient is able to tolerate no problems like hypotension or orthostatic hypotension, in an individual whose blood pressure is going down up to 120, you can probably allow him to go on with the same pharmacotherapy management.
Okay, it's a lot of times this kind of relative hypotension is bothersome to the doctor or the nurse, but rarely to the patient. Because if you look at 24-hour blood pressure readings that are done constantly during sleep, sometimes the blood pressure systolic goes to 80, 70, 60, but the patients wake up without a stroke. So there is auto-regulation, but psychologically, for the family, for the patient, psychologically, you would like to keep the blood pressure around 120 to 130. Has anybody found Dr. Wander? Any comment?
No.
If not, okay.
Sir, I want to make a comment and also a clarification from you.
Yes.
It is our common experience when we treat patients with heart failure and we start them on ARNI and up-titrate the ARNI. We often have seen patients with systolic blood pressure of around 100, but without any symptoms. So
Yeah.
what will be
Yes.
your recommendation? Should we up-titrate when the patient doesn't have any symptom, or we won't? Patients of heart failure on ARNI on up-titration of ARNI has a systolic blood pressure of 100 without any postural symptoms, without any problem. So what do we do? Should we downgrade the dose or continue?
One thing I could suggest is the one hidden problem, if the blood pressure gets too low, is the kidney may not like it. And so I agree that it may be reasonable to let the patient stay with a systolic of 100, but I would like to make sure that their kidney function is normal. In the SPRINT trial, when we pushed blood pressure down to 120 or thereabouts, the outcomes were terrific. But the one side effect we did find was that there was an increased incidence of what they called acute kidney injury. We don't use that term much anymore, but an increase in creatinine. Sometimes quite an alarming increase in creatinine. Someone going from an EGFR of about 60 or 70 all the way down to about 40. Oh my goodness, what's going on? And then you let the pressure come back up a little bit and the GFR becomes normal again. So that's the one thing I would look at. But if no symptoms and kidney function is good, I would keep the treatment going.
Sir, how often you will recommend in such a patient, how often you will recommend checking for the EGFR?
I would do it fairly often, particularly in the sort of patient you described. I would do it at least every 6 months, and if possible, perhaps even every 3 months, just to make sure that the GFR is not getting too low. Because if you keep it too low for too long, it may be an irreversible change. If you identify it quickly and let the pressure go up, it's a very reversible problem.
Thank you, sir.
It's very similar, as Dr. Weber has mentioned, and Roberta, you also know it. If the patient is tolerating that kind of a blood pressure, we should also tolerate it. We should also tolerate it. In fact, in the original carvedilol studies for heart failure, the blood pressure went very low, but carvedilol proved to be very useful. That's why they got approved. Now, talking about the kidney, there is a question, old question, but has come. Why what is the mechanism of ACE inhibitors causing kidney injury in patients with bilateral renal artery stenosis? Usually RAS blockers are contraindicated. Bilateral RAS, the question would be, it happens. Mike, you want to comment? If not, I will.
Yeah, go right ahead.
No, it's actually you have indirectly mentioned with Arnie what will happen if the blood pressure goes very low in the kidney. You already mentioned about afferent and efferent arteriole indirectly. So what happens in bilateral renal artery stenosis is the renal blood flow depends on efferent arterial vasoconstriction. Efferent arterial vasoconstriction that maintains the filtration. In the presence of an ACE inhibitor, you remove that and the filtration falls. When the filtration falls, they might develop acute kidney injury. But hopefully this is not a common problem. But if somebody has known bilateral renal artery stenosis, you are following, then I think one should avoid ACE inhibitor because of this abrupt fall in ultrafiltration that occurs.
The problem, Venkata, and is that most busy doctors do not know whether their patient might have bilateral renal artery disease. And frankly, this is something I always struggle with. There's guys like us who are in major academic centers and we have all those resources available to us. And if you suspect someone might have that problem, you can very quickly get imaging done and see what their renal arteries look like. For so many primary care doctors, and I'm sure that's very much the same case in India, it's a big deal to suddenly say, I'm not happy about this patient, I want you to do renal angiograms. It's expensive, not everyone has access to that kind of thing. So it is a problem and something maybe to think about. If the creatinine is going up for reasons you can't explain, then perhaps indeed that would justify referring a patient to have the vascular studies and see if you have bilateral disease. Good point, Venkata.
Okay, we discussed Arnie, but there is a question on aldosterone synthase inhibitors. Not approved anywhere in the world, but Baxdrostat paper in New England Journal of Medicine and presentation, a lot of interest in it, and two outcome trials. I don't know why they're not getting approved. This is something that has been going on for a long time. Suddenly, endothelin antagonists get approved out of the blue. Suddenly, low chlorthalidone gets out of the blue. But aldosterone synthase inhibitors have been knocking on the door of FDA for some time. As any of the faculty or panelists have a comment, please raise your hand and speak.
I suspect part of it, Venkata, is that the FDA knows that these drugs will be very widely used. They want to have some more long-term safety data before giving the green light. I don't think there's any question about the efficacy of these agents, and there's not much of a question about their short-term safety. But I suspect the FDA would like a little bit more time to make sure that there are no unexpected adverse outcomes. I assume that's the reason for this delay.
Yeah, I think so. I mean, they're very obviously a good alternative to mineralocorticoid receptor antagonists. They're a good alternative, less degree of hyperkalemia, less side effects, good effects on blood pressure. And there is another companion question, drug interactions with aldosterone synthase inhibitors. I guess Dr. Parikh, Anil Parikh, clinical pharmacologist par excellence. If you're still there, can you comment on any possible drug interactions within, we know what might be expected with certain, but can you comment from your perspective?
Interactions between
Aldosterone synthase inhibitors, which are not approved, and other antihypertensive drugs.
I think not much, but maybe where hyperkalemia would be more. So in that circumstances, but otherwise, no. So where you have AC inhibitor, RAS blocker together with them can be one condition where you need to be careful about potassium, particularly when the EGFR is low.
Yeah, that based upon the mechanism of action, and other drugs that interfere with aldosterone axis are probably not generally compatible, but nothing specific that I know, any interaction with other antihypertensive drugs. It has not been reported by people who do this work from Cleveland Clinic and etc. Nothing has been reported. Dr. Egan, Brent Egan, the question is, if you showed some trials of beta blockers with reduced ejection fraction, heart failure, with reduced REF, where you showed the new generation, not completely new, but the second generation beta blockers like bisoprolol are useful. Do you think if they're so useful in heart failure, as Weber has, Dr. Weber mentioned, they could be definitely be useful in hypertension also, right?
They certainly can be, and particularly with patients with comorbidities. I think the commentary that younger patients could benefit from beta blockers because, as Dr. Julius and colleagues have shown, those patients are more likely to have a neurogenic component to their hypertension, often accompanied by faster heart rates. And there are some data, particularly in younger men, showing that beta blockers probably produce a better reduction in blood pressure and less cardiometabolic disturbances than diuretics do. So I think they certainly have a role in the primary treatment of hypertension, particularly in patients with comorbidities and younger patients where there may be a clear neurogenic component. So I think those are particularly useful. The other thing I'll comment, in the US, we do not have very many useful combinations that include beta blockers. We certainly have bisoprolol with hydrochlorothiazide in low dose. We do not have the calcium channel blocker combination. The one that's been used a bit has been chlorthalidone, atenolol. The problem is atenolol is really not a good once-a-day beta blocker, and there have been concerns about that. So I think when you have the combination of bisoprolol and amlodipine with a robust reduction in blood pressure, you would expect multiple cardiovascular benefits. So just a few thoughts.
Okay, thank
Brent,
you.
could I just ask Brent very, very quickly?
Yeah.
A lot of people now in the States are using nebivolol as a beta blocker because it seems to be so well tolerated, doesn't affect exercise tolerance, doesn't affect sexual activity, and so forth. Is that on your radar as a beta blocker worth considering and using?
It is worth considering, and as you know, in the seniors trial, look beneficial in heart failure as well. I think when we're looking for robust reductions in heart rate, we may not see that as much with nebivolol, but certainly, as you say, as a beta dilator, it clearly has advantages in that regard. And metabolically seems to be neutral, unlike some of the particularly non-selective beta blockers.
Thank you, Brent. I think now we have answered some. There are several which I'll try to answer them separately by email or something, because it's late in India. So there are few that I am aware have not been answered. So I just want the people who are asking questions to be patient. You will get a response for sure. So I think let me just make a few remarks. Obviously, the goal is towards greater clarity of this program. done in I would not call it celebration, but in recognition of impending World Hypertension Day and this month, World Hypertension Month. We were fortunate that we had the president of World Hypertension League, vice president of World Hypertension League, and the executive member of the World Hypertension League, Dr. Weber, to be part of the program. So that's a very, very important contribution they have made. I think there is definitely greater clarity now on goal blood pressures, greater clarity on beta blockers, greater clarity on diuretics, clarity on the potential utility of ARNIs for hypertension. The data are there, but until they're approved in more countries, we will not know. But I'm sure that they'll be very, very useful. We had important panel discussion on variety of subjects and kidney, heart, and to some extent brain because of relative hypotension. So I want to thank all the speakers, all the panelists for their participation in this program and their contribution. And I want to thank our academic partner, IPCA, in thinking of this idea to have this global conference a few days before the World Hypertension Day, because on World Hypertension Day, some of the faculty that we have seen today may not be available. So this is a good forerunner to the World Hypertension Day, World Hypertension Month. We had fantastic faculty, fantastic speakers, and I want to thank Johnny, Edwin, and Sachin Nair, Om Prakash, Avinash, and the whole group for all the support they have given in assembling this program. And thinking of this idea was very, very good. One thing I also want to comment, Dr. Narsingan, is in connection with the World Hypertension Month, the whole month, IPCA has a message for all the practicing doctors, one message per day on various aspects of hypertension. So for the entire 30 days, whole hypertension will be compressed to 30 messages, which is a very novel idea. Can I just ask Dr. Johnny Edwin to kindly join and give his comments, vote of thanks, and also suggest about anything regarding the road ahead. When you're walking on the road, there is always a road ahead. So please comment on it. Now, I would like for you to take over, and then you can conclude the program, Johnny.
Thank you, sir. We at IPCA express our heartfelt thanks and gratitude to Professor Dr. C. Venkateswaran, who's the global face in the field of hypertension, and his dedication and the way he has structured this entire program. It was not any molecule specific, it was more of a therapy which we wanted to have, and from the guidelines till now, which has been coined. And we are very grateful to all the speakers for today. Dr. Parati, the World Hypertension League President, and Dr. Brent Egan, Dr. Michael Weber, sir. Whenever we look forward to Weber, sir, always been giving us the space and time. So for the wonderful talk that they've given today, which would be very, very useful for all the faculties who have been attending. And always Dr. Narsingan, sir, for his valuable presence, the Vice President of the World Hypertension League, again, pride for the India, for the country, for being the Vice President of the World Hypertension League. And Dr. Gurpreet Singh Monda, sir, due to his personal comments, which just got a little occupied, that's what he texted me a message. Though he was being available in the beginning, he was not able to join for the last comments. Of course, he also spent his time. He traveled to Delhi, and that is where he got stuck up to join again. So, Dr. Jyotimay Paul, sir, again, a great source of support for us whenever we look forward for academic initiatives. Last year, under the sir's guidance, we were able to reach out to all the medical colleges to create an awareness on the for the public with regard to hypertension control for the country. Dr. Dipti Roy, again, an important face for the Cardiology Society of India, as well as the governing body of the World Heart Federation, for his valuable time. And whenever we go look forward for any initiatives like this, has been always been a supporting hand. And thank you, sir, for your presence. Dr. C.H. Vasant Kumar, sir, the president of the the Indian Society of Hypertension, who has always been an supporting source for and very interested in taking up all the novel initiatives towards the control of hypertension and the cardiometabolic disorders. Thank you. And again, we also have more than 2,000 doctors who have logged in personally, and almost more than 40 centers we have this program being telecasted physically where doctors were present. So I would appreciate and thank each and everyone for, though it was a late hours, but still all being present over there. Of course, from the eastern part, we have the moderator, Dr. Ashish Kumar, Dr. From Patna, Dr. Birendra Sharma from Muzaffarpur, Dr. Siddhartha Mani from Kolkata, Dr. Soumya Deeproy from Burdwan, and again Dr. Kamal Kumar sir from Burdwan, Dr. R.P. Srivastava from Patna, Dr. Bikram Deshmukh from Keshari sir from Bhubaneswar, Dr. Mrityunjay Bera sir from again Cuttack. Again, all their rich experience and the knowledge, and all the medical doctors, the doctors over there. Heartfelt thanks from IPCA Laboratories. Of course, from the western part, we had Dr. Ritikesh Desale from Nasik, Dr. Hardeep Bania from Ahmedabad, Dr. Sadhya Suryavamshi from Pune, Dr. Ram Teke from Nagpur, Dr. Vakmare again from Nagpur, who was chairing the session for today. The moderator at Pune was Dr. Sharmi Kaur, and the chairperson at Nasik was Dr. Ujjwal Kaparnis. So thank you, doctors, for your presence. From the northern part of the country, from Srinagar, we had Dr. Mirdun Shah, who's been moderating over there, Dr. Abdesh Kumar Singh from Lucknow, Dr. Sarosh Ahmad Khan from Srinagar again. From the Delhi part, we had Dr. M.S. Mahar and Dr. Deepak Jain from Rohtak, Dr. Jatinder Kochar from Firozpur, Dr. Tej Bhatia from Hoshiarpur, and of course from Srinagar, Dr. Mirdun Shah was again the chairperson over there as well. Yeah. I think the southern part, we are very delighted to have, of course, from the northern part, we still continue with Dr. Rajesh Kumar, Dr. Mukesh Gupta from Delhi, Dr. Jitendra again from Delhi, Dr. Ram Babu from Jhansi, Dr. Anil Gupta from Delhi, Dr. Ashish Jaishankar sir from Delhi, Dr. Vinod Sahu from Kanpur. From Chandigarh, we had Dr. M.D. Shah. Also, the chairperson was Dr. Sarosha Khan from Chandigarh. Dr. Moderator was Dr. B.S. Jain sir from Chandigarh. And of course, Dr. Akhil Sharma sir and Dr. Gaurav Narayan Gupta sir from Lucknow. And of course, from the Meerut Belt, we had Dr. H.M. Rastogi sir, who was coordinating the entire program. Of course, the guest of honors, Dr. Sanjeev Saxena and Matish Gupta, who are present over there. The chairpersons were Dr. Abha Gupta, Dr. Tanuraj Rohi, Dr. Sandeep Garg, Dr. Saurav Singhal, Dr. Puri Tyagi, Dr. Dheeraj Kumar Soni, Dr. Amit Sharma, and Dr. Amitabh Gautam. So all were present over there at Meerut. So it's a great honor because Meerut, we had multiple faculties over there. From the southern part, of course, we had Dr. Lily Rodriguez from Hyderabad, Dr. Tirupati Rao from Karimnagar, Dr. Tangavelu sir from Erode, again a very, very senior physician of the city, moderating the session over there. Dr. A.P. Naveen Kumar from Vizag, Dr. Surya Narayana from Bhimavaram, Dio Gunalan from Pondicherry, Dr. Pradeep Krishna from Anantapur, Dr. Selomani sir again from the Meenakshi Mission, Madurai, present there. Of course, we had our Dr. A. Murugadhan sir, who traveled all the way from Tirupur to Coimbatore for sharing this particular session. Dr. Ramaraj again was moderating the Coimbatore session over there. Dr. Sandil Kumar from Chennai, Dr. Seji Jonathan Jha from Nagarkoil, Dr. Mohammad Ashad Ali sir from Tanjavur, Dr. Sandeep Kumar sir from Karnool, Dr. Raghavendra from Mehboob, Dr. Vijaypal Reddy from Anantapur, Dr. Manju Bhargav from Cochin, Dr. Shibesh Cochin from Cochin, Dr. Anju Ayavu from Hyderabad, Dr. Bhaskar Naidu from Hyderabad, Dr. Abraham George from Cochin, Dr. C.B. Matthew from Cochin. So it's a great honor to have all of you in these sessions. And of course, as Dr. Ram sir already mentioned, every day there has been a message on various aspects of hypertension and a comprehensive which has been given. And of course, Dr. is none other than from Dr. Venkatram sir, who gives us particular messages to the medical fraternity in India. So we are honored to have this being the month where we have observed the World Hypertension Day. On this line, we have this messages being given. Also, we have taken an initiative of creating the guidelines with regard to home baby monitoring with the Research Foundation of API, where along with Dr. Muruganathan that's one of the initiative. And also we also looked at calibration of the BP apparatus. So one of the projects we have taken in the northeastern part, which will be rolling out to across the country very soon. So we are very honored and delighted to have you all, and thanks. And of course, we at IPCA are the one who initiated the chlorothalidone concept of the low dose 6.25 mg for the globe, and then now the global scenario is also looking at this component of 12.5 mg being approved by US FDA. Of course, beta blockers, we are one of the prominent players supplying most of the API of bisoprolol, carvedilol, metoprolol to the globe. ARNI, of course, is one of the, again, our own initiative compared with the innovator. And of course, the ARBs is again one of the mainstays. So thank you all, doctors, for your valuable presence, and we are honored and humbled to have your precious presence. Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you, Johnny, for all the things. One comment I want to make for people who are still in attendance, it's a scientific program we can put together by identifying right people, which we have done. But the strategy for the technical support, for academic partnership, all these things take so much of a workforce on the ground all over the country, and so many sites you have shown where people were physically present. That's a tremendous work in progress to assemble people both virtually and physically to take part on how to treat cardiovascular risk factors effectively. So scientific aspect, some of us are able to provide, but the other hand required is to how to transmit this information to the real clinicians who are practicing medicine and who are taking care of the patients in the community. So it's an amazing approach, maze that you are able to assemble. Thank you very much.
Thank you.
Michael, you have a comment?
All right.
Michael, you have any comment? Concluding?
No, let me just say it was an honor to be part of this. And again, as one of the representatives of the World Hypertension League, again, thank you for coinciding with this important event with World Hypertension Month and World Hypertension Day. This is a wonderful start to those celebrations, and I look forward to a lot more. Thank you very much indeed.
Thank you, sir. Thank you.
Thank you very much.
Thank you, sir.
Great. Okay, Johnny.
Yes, sir.
Good.